Welcome, everybody. My name is Romaine Gallagher. I'm the Physician Program Director for our program of Palliative Care at Providence Health Care. And tonight's talk is part of a series of educational events presented by Providence Health Care to mark National Palliative Care Week. Our aim is to increase people's awareness about what palliative care is and the benefits of palliative care, as well as improving access to patient care information and resources for healthcare providers. Our educational events tonight and throughout the week have been made possible by donors to the St. Paul's Hospital Foundation. And we thank all of you who are here tonight who donate to our foundation. It's very much appreciated. Now, you may have noticed, you may have sat down on it, but there is a card under your seat. And the reason why that is there is for you to ask a question. So if during Dr. Chochinov's talk you have some burning question about palliative care or about dignity at end of life, please write it down, and then he will address it later. What we're planning to do is Dr. Chochinov will speak for about 45 minutes, then we're going to have a quick break, collect all the questions, and then we're going to have a panel of speakers here to answer the questions. And Dr. Chochinov will be joined by 3 members of our palliative care program, as well as a family member who has graciously agreed to share what he learned through his wife's palliative care experience. However, before I introduce Harvey, and I better put the glasses on, what I'd like to do is, for those of you who are not familiar with palliative care, I'd like to first just give you a little bit of information about it so you're clear about what it is. Palliative care provides an extra layer of support for people with serious illness and their loved ones. It seeks to help them live as well as they can for as long as they can. It's not just for people with cancer. People with lung, heart, kidney, brain disease, frailty, any kind of life-limiting condition can benefit. Palliative care does see death as a natural part of life. Death sharpens and frames life and gives meaning to our time here. But palliative care is not just for those who are near the end of their life, and nor is it the care that you receive when there's no other treatment left. Palliative therapies can be used alongside treatment for the disease, and an example of this would be a person who is receiving dialysis because of kidney failure. Palliative care can be asked to assist with pain management or other symptom management and work alongside the kidney doctors in the care of that patient and their family. And together we work to improve the quality of their life and to help them live as long as they can. Evidence shows that the early introduction of palliative care into diseases such as lung cancer, heart disease, and others helps people to improve the quality of life and actually helps them to live longer. So it's another reason why you don't want to wait till you're almost dead before you ask for it. Palliative care works to address physical, psychological, spiritual needs. In other words, we look after the whole person. You're more than just a kidney failure or more than just a lung problem or a cancer. Palliative care helps identify what is important to the person who is dying and how we can help maintain control and dignity throughout their illness. Palliative care sees ourselves as looking after not only the individual who is ill, but their identified family as well. So, I guess if we could all run through it, I'd make you all say, remember, palliative care is here to help you live as well as you can for as long as you can. And that's what I usually say to people if they really don't want to see that palliative care doctor. They let me in for a few minutes if I say that. So now I'm going to introduce Dr. Harvey Chochinov, and I'm very pleased to introduce Harvey, who's a Winnipeg-based psychiatrist and researcher with a focus on the concept of dignity among people with a life-limiting illness. His internationally acclaimed research has demonstrated that a personal sense of dignity can literally make the difference between a person's wish to live or to die. Dr. Chochinov leads a team of researchers who have developed essential principles and guidelines to help healthcare providers. Oh, I'm advancing your talk and spoiling everything. We're part. Oh my God! I'm so sorry. I'm so sorry. We didn't plan this. At least I won't delete it, Harvey. I'll just stand back. Okay, now can he remember where he is? Okay. All right. So I was talking about Harvey leading a team of researchers who developed essential guidelines and principles to help us healthcare providers and patients and families understand what dignity really means to people and how it can be safeguarded. Dr. Chochinov is the Canada Research Chair in Palliative Care and a past recipient of the Queen's Golden Jubilee Medal, as well as the Order of Manitoba. He also has authored over 150 publications and co-edits the Handbook of Psychiatry and Palliative Medicine, published by Oxford University Press, and the Journal of Palliative and Supportive Care, published by Cambridge University Press. Please join me in welcoming Dr. Harvey Chochinov.
So Romaine invited me here quite a number of months ago and said, you'll come in May, we'll hold an event in the evening, it'll be a beautiful night, and I promise you there'll be lots of people turn out. And I said, Romaine, that doesn't make any sense. I mean, why would a whole bunch of people turn out in a beautiful evening in May? And I have to say, I'm really dumbfounded. This is an extraordinary size group, so thank you all for being here. Let me begin just with this short video because I think it'll put everything else that I have to say into, give you an important perspective. So here we go. My wife was down below with the video camera. I had lots of makeup, a pretty rough landing, I have to say. Anyways, why begin by traumatizing you in that way? Well, it's really to say that, I mean, we all come into this world in a particular way, and any of us, you can sort of think of the metaphor of life being like taking flight. And the moment we take flight, of course, one day we are destined to land. And none of us are immune from that particular trajectory. And it's important for us to bear that in mind because we're not just talking about those who will die, and we're not just talking about those who you know who are ill or facing life-limiting or life-threatening conditions. We're talking about each and every one of us. So it's a very personal issue, and perhaps that's the reason why so many people on a beautiful evening have come out to hear this talk on end-of-life and palliative care. It's hard to talk about palliative care without beginning with the founder of the contemporary palliative care movement, and that's Dame Cicely Saunders. And Dame Saunders, by virtue of hearing about her life, I think really exemplifies what palliative care was about because by way of background, she started out training as a social worker, and then she went on to become a nurse, and eventually went on to train in medicine to become a physician. And her reason for this from the beginning was to try and better meet the needs of dying patients and their families. And Dame Saunders had the idea that to do that, you had not only to meet the physical needs, which of course can be overwhelming and pretty obvious, But the psychological needs, the spiritual needs, the existential needs, these are issues that she felt, in order to deliver palliative care in a comprehensive and holistic way, had to be attended to. Now, many years ago, when I'm not sure that I had more hair, but it was slightly darker than it is now, perhaps, I was invited to St. Christopher's Hospice, and that was the hospice that she had found in London, England. And she had this reputation as being someone who didn't suffer fools lightly. She was a very bright woman, and of course was then knighted, a Dame Saunders. And I remember thinking, when I was invited to speak at St. Christopher's, what questions she might be asking me about some of the papers that I had written. And I thought, geez, I better reread the papers I've written, because what did I say? And I just better be ready for that answer. So I kind of perseverated, increasingly thought about what this visit will be like, and was really kind of worried. And I remember I went down in a taxi to St. Christopher's, and the taxi driver was quite impressed that I was meeting with Dame Saunders, which did nothing to allay my anxieties. And I got to St. Christopher's, and I sat in a room that was really quite kind of both stark and regal in its own ways. And over the microphone, there came this announcement that said, "The Dame will see you now." just like that. And I thought, oh, this is really bad. This is not a good situation here. So anyways, you'll notice that in this photograph, in spite of my trepidation and worry, that both Dame Saunders and I look exceedingly happy. And I can tell you that there was not a single question except one. And that is, and remember this was about 11 in the morning, she said, "Would you care for a sherry?" This was her liquor cabinet, and these are our empty glasses. and that's the true story of my first meeting with Dame Cicely Saunders. So I'm going to make the assumption that all of you are here tonight, not so much because you were so anxious to hear me, but all of you are here tonight because you're frightened of death. And so if we're going to call it for what it is, then I think we need to talk about your death and what that might look like. I'm going to pretend for a moment that this group represents the kind of the Canadian distribution in terms of demographic, so gender, socioeconomic, cultural, geographic diversity, okay? So if we look at the people in, let's just say this first row, including speakers, if you can hold up your hands. First row. Yes, all of you who are... Okay, so you came here early, but so the bad news is, you represent the 10% of Canadians who are going to die suddenly. There's not going to be a lot of forewarning. If it hurts, it will be over quickly. It may be hard on your families, but for you it'll be over, and over very fast. Okay, so that particular group won't have forewarning and won't then necessarily be needing the kind of care that Romaine Gallagher was telling us about. If the people in the next two rows can raise their hands, just the next two rows. Okay, so that represents, about 30% of the Canadian population. And at least according to some of the Senate reports that have come out, I mean, the best estimations that we have in terms of availability of palliative end-of-life care is somewhere between 15 to 30%. So you represent the group of people who will have good quality end-of-life care. And what can I tell you that might look like? Well, you won't die in pain. There'll be people like Romaine and Jill here who will be looking after you, who will make sure that you're pain-free. In about 10% of instances, there may have to be some sacrifice of wakefulness. But aside from that, you'll be comfortable. You'll have a team working with you vigilantly to keep you comfortable at least most of the time. You'll have access to psychological and spiritual supports, although the spiritual suffering can be even a bigger issue to try and handle in palliative care than addressing some of the physical needs. You're much more likely to die in a place of your choosing. In fact, a palliative care program such as the one in Winnipeg, and I don't know here in Vancouver, but the prevalence of home death is anywhere from 70 to 80%. So the chances that you would die in a place of your choosing are much greater if you are able to avail yourselves of palliative care and have those end-of-life conversations that indicate what you would like. And if your palliative care program is affiliated with home care services, which many of them are, then it's likely that you'll have access to home care, that your families will feel less burdened, and that you'll have access to a palliative care facility if and when your family members either are feeling it is time for that option to be invoked, or your wish would be to die in a hospital, in a palliative care setting, rather than at home. Okay, the rest of you who haven't raised your hands, if you could raise your hands now. And the rest of you, if you can just sort of look around, sort of and you're thinking, I'm seeing somebody laughing, saying, why did I come late? That's right. You know what you're in for. So here we go. So you represent the 70% of Canadians who will not have access to good, comprehensive, quality palliative care. By the way, for those of you who are living in a major metropolis like Vancouver, the likelihood is that you'll have good access to care. But again, we're asking for this to be representative of, the Canadian landscape, so to speak. So for those who won't have access, their pain may or may not be well controlled, and it really depends on to what extent their care provider has good skills in treating pain. And we know that the level of expertise amongst many physicians is not what it should be. You may or may not have access to, and in fact, if you're living in northern or remote regions of the province, it's unlikely that you're going to have access to vigilant symptomatic symptom relief. And palliative care is more than soft music and dim lights. I mean, palliative care is an area of medicine that very vigilantly will go after and even aggressively make sure that you can be kept as comfortable as possible. Psychosocial expertise outside of major centers is really lacking, and people tend to be on their own. About 75% of Canadians will die in institutional settings, so the likelihood that you get to die where you might choose is less likely for those without access. And that is more likely to leave your family feeling exhausted, for you to end up feeling like you are a burden. Now, why is all of that important? It's important for, of course, a variety of reasons, and it's to say that the larger discussion, and the discussion I know we'll be having today, is around palliative end-of-life care. Unfortunately, the entry point usually for these sorts of discussions are around the construct, the issue of euthanasia and assisted suicide. That's usually the entry point. Whenever we have discussions as a society, we tend to have those discussions around some case that involves whether or not an individual has the right to choose the timing, the circumstances of their dying by virtue of assisted suicide and euthanasia. If we were to look at a group of about 1,000 people, and now taking the demographics from the state of Oregon and literature from Oregon, the truth is, if you look in Oregon, about 1 in 6 people will have a conversation about the possibility of physician-assisted suicide with their family member. So in this group, maybe about 50 people or so. About 1 in 6 will talk about it with their family. 1 in 50 will take it forward to their physician. So if 50 people talk about it with their family, about 5 people will then take it forward to talk to their family physician. Now, if you look at the situation in Oregon where they have physician-assisted suicide, about 10 people out of every 1,000 people who die will actually have the conversation and ask for a prescription for physician-assisted suicide. Of those, 2 in 1,000 will receive a prescription, and then finally, about 1 in 1,000 Oregonians will actually die as a result of assisted suicide. So that puts it into perspective in terms of the magnitude of these conversations. Euthanasia, assisted suicide, of course, it's a small part of the conversation, but I think it's a conversation that really is generated from the fact that all of us hold in common, and that is that there is this fear of how we will die. Maybe the last word I'll say on the assisted suicide is that when I first started publishing some of my work on dignity and how we could do a better job of addressing dignity-related needs in end of life, the then head of the Hemlock Society, a woman named Faye Gersh, wrote the following in the Journal of the American Medical Association. She wrote, "Still, if most individuals with a terminal illness were treated this way, the incentive to end their lives would be greatly reduced." So I wrote her back and I thanked her for the endorsement and thought, perhaps the Hemlock Society might eventually redirect some of their monies into research so we could do better at making sure that we meet the needs of patients near end of life with means other than offering them a means to end their life. Now, you're probably wondering, well, how do you actually go about trying to research something as difficult, as seemingly kind of nebulous and vague as how people cope towards the end of life? And I can tell you that it's not an easy thing to do. It's certainly incredibly intriguing. And over the years, the intrigue and the interest for me remains high and really intense. So this, for example, gives you a piece of data on a woman who was in our study and she was dying of end-stage colorectal cancer. She's filling out something called a visual analog scale so from 0 to 100, and don't worry about the details of this, I will kind of give you the explanation. She is telling us what is her will to live at any given time, and she's filling out this measure daily. You can see when she comes into the palliative care unit, her will to live is poor. Anything that scores high means she's in distress about this. And her will to live then immediately improves. So she gets a much better outlook once her pain is under control, once she's in the palliative care unit. And as a case in point, this is that same woman and the pattern of her will to live, and superimposed in red, you can see what her pain issues are and how her pain seems to correlate with something as spiritual, something as fundamental in her outlook as the wish to go on living. I was speaking at St. Paul's today and speaking to the medical staff there and saying, if we were using a dance metaphor, this is a tango. We see this intimate connection between this woman's experience of being in pain and the very wish to go on living. And in many ways, this is really emblematic of what palliative care is about. We get people who are experiencing, a variety of symptoms, experiencing a variety of distress. And the idea is that if we can change that, if we can make people more comfortable in this instance, it's very clear what you see is that they regain the wish to go on living and life continues to be something that has value and meaning and purpose. Now, we then started to, in fact, I said I wasn't going to say too much about assisted suicide, but one more piece. We began to study the notion of dignity largely because of something that we saw from data that was coming out of Holland, where they'd been practicing euthanasia and assisted suicide for quite some time. And what the Dutch reported in their experience, and this comes from physicians who've actually taken part in death hastening, these physicians were asked by the government not only how often does this happen, but why? Why is it that you as a physician have been asked by your patient to undertake this really very dramatic, profound, and irreversible measure on their behalf? Loss of dignity was the most highly cited reason, more so than pain, more so than any other reason that was cited by these physicians, loss of dignity. And yet, at this time that we came into this work, no one had done any studies on the issue of dignity. There were absolutely no studies that had spoken to patients near the end of life and said, well, if dignity is important, if dignity is the thing that might make life worth living or at times makes life seem like it's something that you want to relinquish, can you help us understand it? And so that's when we began doing studies on the issue of dignity. Here comes my happy slide. Romaine, you gave away the punchline. They already know what I'm going to say. So what did we find? When you look at people who have lost their sense of dignity, and this is comparing them to people who feel their dignity is intact, thank you very much. And again, don't worry about any of the numbers, they're unimportant for the purposes of tonight's presentation. But what we found is if you lost your sense of dignity, you were more likely to lose, the very will to go on living, kind of the thirst for life. That just seemed to wane, along with experiencing many of these psychological difficulties, these psychological issues. We also found that dignity and loss of dignity was very much related to the physical experience of being near end of life, whether it was something like pain or even physically, how the illness had begun to change our own appearance. Again, I emphasized this today in my earlier talk at St. Paul's because I think, this audience is coming at this, I imagine, largely as consumers, as people who are coming to care, to receive care, and hopefully looking forward to compassion in that care. And one of the things that I told this group of care providers is that there are some things that happen in hospitals every day, and they're so common, they're so routine, that they really fall entirely off of our radar. We stop paying attention to the fact that things like bathing, dressing, toileting, those are very, very ordinary occurrences. I mean, if I spoke to any medical student or resident or member of the staff and said, well, are you aware that these things have been going on? I said, look, I've been pretty busy today. I mean, I haven't even given it a second thought. And the truth is, we don't give it a second thought because it's ordinary, except when we think of somebody who we love or we think of ourselves. And then these, what we've called the intimate dependencies of care, and I think it's an interesting and a lovely turn of phrase, intimate dependencies. These things, of course, are the things that turn our world upside down. These are the things that can undermine our dignity and even will to live. Now, the epiphany in some of this work for me came towards the end of this study that I've just shown you, which was looking at trying to understand how people's dignity is shaped. And at the end of the study, we asked the research question, is there something over and above everything else that seems to predict, that would predict whether or not you would feel that your dignity was intact or not? And believe it or not, even after we had measured pain and we'd measured anxiety and depression and existential, spiritual, psychological issues, we measured all of those things. And the one thing that came out as being more predictive of sense of dignity than anything else was this notion of how I am seen, how people see me. It's worth pondering for a moment. And again, it was this epiphany because what it said is that to be good at caring for people, and I think this applies, although we discovered this in palliative care, I think this probably applies, across the broadest spectrum of medicine. To really feel that you have been cared for, what the data seem to say is that patients are looking at us, the care provider, for some kind of affirmation. They're looking for something that says, I'm more than just a patient, or I am more than just my illness. I wrote actually a separate paper on this finding that I called Dignity in the Eye of the Beholder. And what I try to put forward is that the beholders of care are the people who provide care, and that patients are looking in our eye, the care provider's eye, for some reflection. And when I found this photograph, I thought, this is perfect. Because what you see is an elderly gentleman looking in the eye of a care provider. Now, if he saw nothing, if he saw no reflection, then he might feel that, the essence of who he is has disappeared or hasn't somehow been acknowledged. If he only saw his illness, he only saw the weird blood test or the lump or whatever it is that brought him to medical attention, then many of us in this room, because all of us have been on the care receiver side. And what do you hate about being a patient? Well, it's feeling like the only thing that is being seen is the ailment, that you're being defined in terms of that ailment. But the lovely thing that's reflected in this photograph is this man sees himself. He sees himself in his own surrounding. So he's seeing a whole person. And so the message for healthcare providers, it's empirically based, it comes from the data, but the message for healthcare providers is that when you walk in the room, metaphorically, that reflection that patients see makes the biggest difference in terms of whether or not they feel their dignity is upheld versus not. Now, over the course of the years, we've continued to do studies on this issue of dignity. And what have we found out? Well, I called this paper Dignity Conserving Care, a new model for palliative care. So what's new about this model, and how does this model look? Well, this is the model that was informed by information that we obtained from dying patients. So none of this is the Chochinov model. I haven't been dead yet, not even once. But this is what our patients told us, who were all, and again, all of our studies are with patients who are near end of life. Their life expectancy is under 6 months. They're usually, on average, in their early to mid 70s. About 80% of cohorts who are in our studies have an end-stage cancer of some form or another. What did these patients tell us that we care providers should be attentive to if we're going to do a better job of looking after people? Well, they said, and this is the illness-related concerns, you better look after some of the things that are caused by my illness. So, for example, things like symptom distress, and that's a very typical thing that palliative care docs worry about and are great experts in. But what else did we learn? Well, if you start looking at some of the granularity that came out in this model, psychological distress, but for some people, something called medical uncertainty or death anxiety. What's that about? Well, some people were saying the thing that causes me angst is not being able to predict what's going to happen. I've had no practice at this. I don't know what it's going to look like. Another hat that I wear, and I'll be talking about this right towards the end of this brief talk, is I'm the chairman of a national project called the Canadian Virtual Hospice. Romain Gallagher, who's a physician here in Vancouver, is one of our consultants and works as a virtual physician on the Canadian Virtual Hospice. The most frequently downloaded article from the Canadian Virtual Hospice, and that's virtualhospice.ca, worth writing down, is When Death Draws Near. So, and it sounds kind of macabre when you think about it. I mean, really, people are downloading an article called When Death Draws Near? But the truth is, it's hard information to access. Sometimes it's even hard to kind of know how to put it into words or who to talk to about it. And to get information that is written by professionals in lay-friendly language, in language that's not going to be emotionally abrasive, that's going to be very accessible, is not easy to come by. And so it lends empirical validity to what our patients in this particular study said, which is not knowing what to predict. I mean, that leaves me feeling like I'm in an unsafe place and I'm walking in the dark. The next area, and we call this the dignity conserving repertoire, a fancy title that really refers to, who is the person in terms of their psychology, in terms of their spiritual outlook. Who is that person who comes to the experience of illness? And many of these things, and again, I apologize if the print is small, are about personhood. And it's an important issue, and it's not an issue that we talk very much about in medicine. And I'm going to show you a study towards the end of my talk to say, how can we put personhood on the radar? Because again, as I said, the great irony is all of us in healthcare spend our entire academic life learning how to look after patients. And the big irony is no one wants to be a patient. Because the moment you become a patient, you feel like you're having to give up personhood. And that really ticks us off. I mean, nobody enjoys that. So all of these things that we found in the dignity model were about how can you speak to things that have to do with the essence of who that person is. Their roles, the things that give them meaning. This issue of generativity basically was the idea that for some people, dignity, the final assault on dignity, is the idea that their life won't have left any kind of ripple effect. What meaning will my life have had? What influence will the fact that I was here have on those who I'm leaving behind? And then finally, something that we call the social dignity inventory. And again, this gets back to this notion of the reflection and affirmation. There are things that as healthcare providers we can do that can make you feel your dignity is upheld or not. We can respect privacy, we can provide you support. But then we introduce this term, care tenor, the tone of care. I was talking to a group of oncology nurses, and one of the oncology nurses said, "Oh, I know what that's about. That's the fragrance of care." She said, "It's that something that patients sense the moment you walk in the room." And I said, "Well, explain that to me." And she said, "Well, it's not about necessarily what you say or about what you do. It's the nuances, it's the tone that somehow is established in the room that lets that person know whether or not you care or you don't care, whether they matter or they don't matter, whether at some level it's registered with you, the nurse, that you, like them, are a human being in this moment of their need. And the interesting thing about care tenor, and I've had the great privilege and opportunity to present in healthcare settings around the world, when I talk to not only healthcare providers, but senior administrators, they say this is the reason that we get into trouble. Medical misadventure happens occasionally, and I mean, it's a terrible tragedy when it does. But the thing that happens all too commonly is a lack of appropriate care tenor. Somebody's been on call, it's late, you're tired, this is, you've seen lots of patients, and you just stop thinking in the moment that, oh, right, this isn't an automotive industry that I'm in. I'm not dealing with things that are made of steel. That's right, flesh and blood. Oh, right, people. I wrote an article. It sounds like I didn't go further than kindergarten. I wrote an article called Patients Are People with Feelings That Matter. My mother was very proud of me. She said, I told you that when you were in kindergarten. I said, yes, Mom, and look where it's gotten me. So the care tenor is important, and all of these things, the reason we're talking about them is that if we are going to be attentive to issues of dignity, I'm just saying that when we talk about the right to dignity or dignity in care, that very oftentimes the word dignity is construed with the whole euthanasia, assisted suicide. And I guess the point I'm making is that there is a great deal more to dignity than simply that. It is a way of being with patients, it is a way of managing patients, and it's a way of being cognizant of the multitude of things that might influence the experience of people as they're approaching end of life. So, how do we teach healthcare providers to do this? How can we convince them that this is something that needs to be done? I said earlier today that in critical care, we have something called the ABCs of critical care. A is for airway, B is for breathing, C is for circulation. Did I get that right, Jill? Yeah, good. Got that right. Now, if Romaine Gallagher started to choke to death and was taking her last breath, and I, as a psychiatrist, ran up to her, held her hand, looked into her eyes, and asked her if this reminded her of some early childhood trauma, as she then died in my arms, you would look at me and say, that is the most ridiculous thing I've ever seen. And if I said, look, I'm a psychiatrist, I gave her professional empathy, you'd say, that just doesn't cut it. I mean, if you can't call yourself a physician and handle, poor deceased Romaine the way that you did. So if I can't be absolved of those ABCs of critical care, why is it that in medicine writ large, the core efficiencies of the humanities of care are just kind of trust your gut, do what feels right, follow your intuition, just try and be a good person, because we know that people mess up. So that's where I wrote this article in the British Medical Journal called The ABCDs of Dignity Conserving Care. What does it look like? Well, A is for attitude, and I've said how the attitude of the care provider makes a profound difference. And if I just skip ahead, the thing that was most highly endorsed amongst a group of dying patients that affected their sense of dignity was feeling a burden to others. I feel like I don't serve any purpose any longer. And by the way, that has been associated with interest in assisted suicide, euthanasia, desire for death, loss of will to live in any study and every study that's been done. But equally as important and equally as endorsed by this group of dying patients, not feeling treated with respect or understanding. And where does that come from? That comes from us. And I think this is true of whether or not you're a care provider or whether or not you're a family member. Can you continue to treat a person near end of life as though they are deserving of honor, respect, and esteem, which, by the way, is the dictionary definition of dignity? So, what would that lead to? Well, if your attitude shifts, Then your behavior shifts. So when you're at the bedside, do you stand or sit? Do you meet their gaze? Do you avert their gaze? Again, something that's very ordinary. Doing a physical examination. Those of us in healthcare say, completely routine, so routine that I'm going to fall asleep. It's boring, it's so routine. It becomes less boring and less routine when it's your body that is being examined. And so something as simple as acknowledging that reality by saying, I would like to do an examination. Is that okay? It says it is your body. Can we do this examination? And I think that acknowledges that realization. And then finally, this idea that in medicine, and you hear some really odd and difficult stories. In medicine, we sometimes use the rationale that there is no cure to be a rationale for I don't really need to be present. The other day I was giving a talk and somebody shared an anecdote where they were on a busy surgical service with a very powerful, imposing surgical attending. And they said that the patient, this physician, years after the fact, recalled this physician tiptoeing by the room of the patient who is now on the terminal course so that he could avoid going in the room. Why? Because he felt helpless and didn't have perhaps the wisdom to realize that being there is of profound significance. And of course, what you realize, what you learn, certainly in the work that we do in palliative care, is being there means everything. Because once you're there, you can start becoming attentive to all of those multitude of things that I shared with you that can influence sense of dignity. Compassion could be the topic of a completely separate conversation. And compassion is this idea of understanding the suffering of another and wanting to be attentive to it. What I tell healthcare providers is I think the opening to compassion really is the realization, and again, I think that's why the video is so important, that all of us are on that trajectory. It doesn't matter if you're a healthcare provider, if you're a patient, there's a very permeable membrane between those. And if you don't have that realization that you, like your patient, are vulnerable, compassion just becomes this very intellectual thing, but not necessarily something that you can relate to in a very fundamental way. One of my colleagues is a disability advocate, Dr. Jim Dirksen, one of Canada's really outstanding disability advocates. He has post-polio syndrome, has been a wheelchair user for much of his adult life. And one day we were having a conversation, and it was a friendly conversation. And he said to me at one point, well, Harvey, as much as I like you, I thought, okay, where's this going? I said, Harvey, as much as I like you, you are a tab. I thought, tab, okay, Jim. I thought we were getting along fine up until now. Exactly, what do you mean by that? Tab, T-A-B, temporarily able-bodied. Oh my God. I felt the same way. I thought, oh my God. It's sort of this bit of like an existential slap in the face. But then I realized, it wasn't delivered with malintent. It really was meant as, I think, an important reminder that as much as we talk about issues of vulnerability, disability, palliation, we're not talking about us versus them. It really is about we. It really is about the human condition. And then finally, D is for dialogue, or the conversations that we have with people. And how can we do things to let people know that we are dealing with them not just as patients and not just to find the conversations around the ailment that they have, but that the person that they are. And some people make this out to be extremely complicated. Maybe people like me who are psychiatrists or social workers, psychosocial experts, and our medical and surgical colleagues get impatient and say, if you want to spend time, walking in the woods, meditating, getting in touch with your inner child, you do that, because I got lots of other stuff that I need to do, and I'll just make the referral to you. But I think what we need to point out is that it doesn't have to be so complicated, and sometimes it can be those nuances. I remember not so long ago, I was at our cancer clinic, that's where I have my office. I was stepping into the men's washroom, and the door adjacent to that is where Dr. Johnson, who's a hematology expert, was entering into the room to go see his patients. And as our adjacent doors were closing, the last thing that I heard Dr. Johnson say to his patient was, "So how was that vacation?" Click. Now, I have no illusion about the fact that they were not sitting in that office 10 minutes later looking through a PowerPoint presentation of the latest vacation that they took. It was in the moment just a recognition that, yes, we're here to talk about your lymphoma. But I'm also curious, so how was the vacation? It's these tiny nuances that help the patient understand and feel, they get it. They understand that I'm something more than my lymphoma. I'm something more than my accounts. And it can be as simple as, this must be difficult. This must come as a shock. I'm sorry to have to tell you this. I remember I had a senior consultant who was one of my mentors, and he just had a way about him. I mean, now that I have the language, the care tenor, he had a way of walking into a room and just looking at someone. It was a look in his eye, and sometimes it was just a gentle hand on a shoulder or forearm that just let people know, even before he'd opened his mouth, that he got it, that he understood what was happening, he understood the pathos, he understood his own humility and the things that he could and couldn't change in the face of what was unfolding. Now, in our research group, we've tried to do a variety of interesting things, or I find them interesting anyways. Somebody's got to. One of the things that we came up with was a novel, brief psychotherapeutic intervention that we coined dignity therapy. I wrote a book that was published by Oxford University Press called Dignity Therapy, Final Words for Final Days. And it describes this brief psychological intervention that invites somebody who is with a life-threatening, life-limiting illness to engage in a facilitated or guided conversation. The conversation, because of the issue of generativity, we know is something that we would hope can be recorded, transcribed, edited, and given back to that person so that indeed out of this transaction comes something that can even transcend the event of their very death. So this idea of ripple effect, how can I influence or how can I leave something behind or something that will have some form of permanence? Well, this allows a patient who feels that this form of generativity resonates with them, the ability to do that. I had a patient once, a man with end-stage malignancy who was a pilot. And because of his cancer, he'd stopped flying. But for him, his form of kind of artistic expression and generativity, if you will, was he was a wood carver. And so for him, near the end of life, making carvings, creating pieces of furniture that he was going to give to each of his family members was his way of expressing the need for there to be something of permanence. So I'm not saying that this is a panacea, but dignity therapy uses the form of words and capturing those words in a document that people can bequeath to a loved one. The conversations in terms of the content, again, is guided by that model of dignity that I showed you. So we ask about things that really are about personhood. So what are the things that are important? Are there memories that are particularly salient? Are there things you would want them, others to know, to remember? Hopes, wishes, or dreams for particular individuals in your life? Words of guidance, things that you would want to pass along, and so on. And that gives you the gestalt. Because we're researchers, we have been doing a variety of studies. We've done phase 1 studies. We've done phase 3 studies, which are randomized control trials, so randomly assigning people to an intervention arm and standard care. And this form of intervention has now been offered to people in various settings around the world, China, Japan, Australia, New Zealand, Denmark. Just this last week, there was another study that came out in Portugal, and last month, there were some studies that came out in Australia looking at the positive effect that dignity therapy had on family members and patients who had neuromuscular disorders, including ALS. So maybe just to give you a quick, brief example of how this looked. One of the first patients who came into the study was a gentleman who'd gone on a hunger strike. He had end-stage colorectal cancer, and he had said that, his words, breathing has become redundant. Those were his words. He was a lovely gentleman. So he came into hospital because oncologists were starting to get nervous about the fact that this guy had gone on a hunger strike and wasn't eating or drinking, and maybe you should bring him in and have the psychiatrist look at him. And I think the fantasy was that I would see him, that I would sprinkle Prozac on it, and everything would get better. Well, I mean, this gentleman was, not only was he lovely, but he also wasn't suffering from any kind of psychiatric ailment, as best I could determine. But he did say to me when I walked in his room, if I could press that button now in that European country, I'd do it. And you know exactly what European country, and you know exactly what button he's referring to, which made me think I've got my work cut out for me. Did an evaluation. At the end of it, I said, look, I mean, giving you Prozac would only make them feel better, and it wouldn't do anything to make you feel better. But if you're interested, here is something that we as a research group are going to be starting to do. And I explained how this would work, that if he was interested, I would come back the following day, and there's this kind of ethos of immediacy. I mean, if your words are important, if I'm trying to impress that you continue to be important, then you don't want to be put on hold. And so I said, I will come back tomorrow with a recorder. We will have a conversation, and we'll see what happens. I will lead you through the questions. And oftentimes, in fact, in every instance now, as part of the protocol, we give people the framework of questions so that they can begin to mentally prepare themselves for what this might look like. He thought this was a lovely idea. Thank goodness. It changed the next years of my life. Had he said, that's really kind of silly, I might not be here talking to you about it today. But as I left the room, I said to him, so if you could press that button now, would you? And he looked at me with this sort of sheepish smile and said, well, no, I'd like to do this first. Well, I went to the medical oncologist, Paul Danig, and I said, Paul, it's like palliative care penicillin. Look what we've discovered here. Anyways, I came back the following day, and he, in spite of being quite ill, he said, we would do this. And he sort of perched himself up on his pillow, and he began to talk. And I've seen that happen in so many instances, where he talked about his life and coming from the old country. He talked about his parents. He talked about there were white Russians and red Russians. For all I remember, there may have been pink Russians. There were lots of Russians in the story. And he came to this country, and he talked about his children, and he talked about what he hoped for his wife, given that she would certainly outlive him, and what he hoped for her. And so it was a marvelous, marvelous telling of his story and wishes. And we then transcribed it. We came back. There was not very much editing. He was a very articulate man. We gave the document to his wife. He was too weak, actually, to take it from our hand at the time we returned it to, and her words were, this will be a blessing to our family. We've done multiple studies, there have been multiple studies, and basically, without going into detail, what you can see is that, well, it's not palliative care penicillin. People say, yes, in most instances, this does improve my sense of dignity. This does give me a sense of heightened meaning and purpose, and a sense of having something to continue living for. And when we have spoken to family members 6 to 9 months after the death of their loved one, what we have found is they've said, this really helped my loved one. In 65% of instances, and again, don't worry about reading the numbers, I'll read the important ones to you. In 65% of instances, the family member said, this helped, and again, this is a single, brief, psychotherapeutic intervention, non-pharmacologic treatment, and they said this helped in 65% of instances as much as anything else that was done on behalf of my now departed loved one. And they also said that it had an influence on their own sense of grief, that it helped in their time of grieving and mourning. Let me take just 3 more minutes, so we'll be relatively on time, because I'm all that stands between you and a coffee break. So ultimately, although the dignity therapy is rather high intensity and takes a certain amount of training and skill and time, ultimately the message that I'm trying to give to care providers is how can we make it really simple in terms of fundamental things that you need to be doing with your patient. person. So how can we put personhood on the radar of every healthcare provider? And I'm not just talking about the doctors and the nurses, but I'm talking about anybody who has contact with patients. It could be the person working in medical transport. It could be the triage nurse, maybe especially the triage nurse. It could be the person who answers the phone, the receptionist. How can we change their lens? So we can't necessarily change what the patient has experienced, but if we can change the lens of the healthcare provider to see you, the patient, in a different way, so that they see a person, not just a patient, that is something quite profound. And that's why, again, this image is so powerful, because we see somebody, or we see a couple of people who are checking out a new lens. So what can we do to provide healthcare providers with a new lens, a new way of looking at people that they care for? Well, here's a really simple question that I would suggest that everybody in medicine, whether it's from cradle to grave, could benefit from asking their patients. What should I know about you as a person to take the best care of you can? We've done a study where we've asked this of about 130 or so patients and family members. Once we ask it, we go off and we summarize the conversation. We come back and we read what is a paragraph or two, no more, and we say, is it accurate? And then the litmus test. Would you want this on your medical chart? Well, if this is the lens you would want everyone to look through, then you would think you would want everyone to see you in this way. This is what a First Nations woman told us. And again, it's a very brief conversation, a few minutes. And here's what she said to us. And this is the summary, because she said, yes, I would want that in my chart. So she's a First Nations woman in her late 60s, early 70s with an end-stage cancer. And it says, Mrs. F says that because of the residential school, she always had a hard time trusting people. She, in fact, moved 82 times so as not to let anyone get too close to her. Well, this has gotten better over time. She still struggles with being able to trust people. She wants to, but it's hard for her. She sometimes worries that she won't be told the whole truth, or that people will see her as not being deserving of the whole truth. She appreciates people being friendly towards her, but is frightened of authority figures. Authority scares me, but I'm not as bad as I used to be. And what I said to the medical staff today when I shared this particular anecdote, I said, now can you imagine being the healthcare provider looking after this woman and not knowing this? It's kind of like walking through your care day to day with your eyes closed. You know, you could feel around doing some technical aspects of care, but you really don't know this person. You know, even the fact that you walk in with a white coat. She told me she was afraid of white coats. Immediately, there is subtext that we're completely unaware of. Okay, 2 more slides, and then we'll stop. What did we find? Or it may be 3 more slides. So what did we end up finding in this particular study? Well, here's what we found. We enrolled about, as I say, just under 130 patients and families. Families responded to the questions when patients were too sick. What did the patients end up saying to us? They all said it was accurate. Nearly everyone, without exception, said, if you're going to walk in my room, them's the glasses I want you to be wearing. So 97% said, yep, that's what I want people to see me, or that's the lens I want people to look through. Many of them wanted copies. 93% said this information is important for their healthcare providers, and just over 80% said, just knowing how I've responded to what you need to know about me as a person could affect my care. And all of them, almost without exception, said, every patient, every family member should be asked to do this. And then finally, when we then looked to the healthcare providers, we said, so what did you make of this experience? In 90% of instances, and this is really interesting, in 90% of instances, the healthcare provider said, well, I learned something that I didn't previously know. And in about 60% of instances, they said, it heightened my sense of empathy, my sense of emotional connectedness to that person. So in closing, 2 things. One is, think about the Canadian Virtual Hospice as a resource that you might like to go to. I've done a lot of talking. We're going to have a break now, and you're going to have a chance to ask some questions. But even though we've got a wonderful panel of people who will be responding to questions, I assume that there will still be things left unanswered. The other thing is that when you're not living the experience, I mean, if you're not dealing with somebody who is dying or somebody who has life-threatening or life-limiting illness, these questions just may not be a part of your mindset right now. So keep in mind the Canadian Virtual Hospice. If it's not something you need to go to today, it's something that you may need to go to in the future. And currently, there are over 1,500 Canadians every single day who are going to the virtual hospice for information, support, who can even post individual questions and receive individualized responses. So with that, I'll say thank you for your attention. Let's have some coffee and then reconvene for our panel discussion. Thank you.